it comes with the evolution of endoscopic spine surgery. So we'll discuss about what is endoscopic spine surgery, the operative steps, the current position of spine endoscopy, and why you should have it as a part of your lifestyle in your spine, in your practice, and my personal experience. So goal of any minimally invasive spine surgery is smallest possible surgical footprint, minimal collateral damage, achieving a similar goal of that open surgery, and better functional outcome for the patient. So these are ultimate quest for any spine surgeon to have for having a good results for the patient. So what is the collateral damage in spine surgery? Normal conventional spine surgery, you are prone to damage the paraspinal muscles, the interspinous ligaments, the supraspinous ligaments, the lamina and the facets. These are very much important for maintaining the sagittal balance of the spine. So anything, though you are trying to constantly quest to do this minimal damage, that's how the endoscopic spine surgery has started. So this is the cadaveric cross section of a normal L4, L5 space. You see the interlaminar window. Entering that, you need to go from this, you have a marker? So you see, entering the target area requires a lot of dissection, and you know we always have something called tunnel vision. So when the patient's weight is increasing, when the patient's having a big issue of BMI, so you are going to damage starting from here, from the fascias to the multifidus muscle up to here, and when you go depth, you are prone to injure more. So this is a post-operative patient of a regular L4, L5 laminectomy. Patient has undergone a single level laminectomy for L4, L5 stenosis. You can see the amount of muscle damage and muscle atrophy in the post-operative MR of a open lumbar surgery. So this constant quest has started with initially with open surgery, then mini open techniques, then minimal access spine surgery with tubes, then percutaneous endoscopic surgeries have been started. So this constant quest to avoid this collateral damage, it initially started to using surgical loops so that you are not destroying much of the bone. Then they started using microscope, then endoscopic assisted procedures like dust induced, and true endoscopic spine surgery. So these are the scars of open surgery, mini open or microscopic surgery, and this is the scar of endoscopic spine surgery. So what is true endoscopic surgery? A incision is less than 1 centimeter, no muscle cutting but only muscle splitting, so almost no post-operative pain, so good functional outcomes, preservation of the sagittal balance by not destroying much other structures. So just your target is a sniper. You just put your gun in the window and start doing your work. In normal surgery, what you start seeing the lamina, you feel it is the end point of surgery, you are very happy. Here my starting point of endoscopic surgery is seeing the lamina. So we are avoiding muscle damage, we are avoiding unnecessary time waste of surgery. Once you pick up the learning curve, endoscopic surgery is more faster surgery than open surgery. So according to me, there are only two endoscopic surgeries. It depends upon the approach. One is a posterolateral approach or a transforaminal surgery. The other is the interlaminar surgery. You can consider interlaminar surgery can be monoportal or biportal. So, but there is only, it's always the approach based endoscopic surgery. So one is a posterolateral approach, the other is an interlaminar approach. So diagnosing, using of the algorithm, finding out which approach is best for it, these all will be discussed in the next lecture. So we are just talking about evolution of endoscopic surgery. Initially transforaminal surgery was started because of the Pervez-Campbell's triangle. So when Campbell started, you can hear me? Yeah. So when Campbell had started finding out the safest triangle in the spine, Anthony Yang, all the yes system, then Professor Rutten taken up transforaminal. So they started putting in a deal, then started using dilators. So they were entering the disc space. They were constantly seeing that how to prevent the external root injury. So they were initially able to do foraminal stenosis. So they were able to do foraminal disc herniations. They were able to do more lateral approach and do central disc herniation. Then came the chance for doing L5S1 where there was a problem with thick facets and high iliac crest. So initially transiliac was done. So but it is an expertise job. Then they started using the same scope into the interlaminar window because God is gifted. So where difficult one issue is there, God gives other path for us. L5S1 transforaminal approach may be difficult, but interlaminar window is usually wide. Similarly, in the upper lumbar levels, it is the interlaminar approach is difficult. The transforaminal approach is easy. So always there is some good bailout for us. Knowing both the techniques is very much important when you want to become a true endoscopic spine surgeon. So indications initially were degenerative disc prolapse, either central, paracentral, foraminal, extraforaminal, then started with canal stenosis, then lateral stenosis, then listhesis, fusions, then facial cyst. Now even we started doing intradural tumors, synovial cyst and other kind of stuff. So I feel endoscopy is just a joystick of your eyes in the spine, which is more flexible and more reachable into the corners. So imbibing the technology of using endoscope with dexterity, your limitations are impossible. So you can't stop it. You can, wherever you feel you can do it, you can use it. So positioning and all, the next lecture is going to be about it. So I am not talking about that. This we'll discuss it later. So we'll talk why endoscopy is ahead compared to other techniques. First, better visualization. You can see the nuchal corner of the spine. So you can see the traversing route, you can see the central cord, you can see the opposite traversing route. Sorry. You can look at all the corners of the spine. You can go to the shoulder, you can go into the axilla. And also you can do contralateral traversing to decompression. So complete decompression, what you feel is you expect in an open surgery can be achieved with true endoscopic spine surgery. The opposite foramen where the traversing route is going to exit, up to there you can go give good decompression. You can see the caudal lamina, the final attachment of flavum is removed, so it is complete decompression. Of course, small scar and minimal surgical footprint. This is the post-operative scan for an open spine surgery. This is the post-operative scan day 1 of a endoscopic spine surgery. You see the multifidus is intact. You see the supraspinatus, infraspinatus muscles are intact. There is no just facial splitting, so you won't see any much of edema near the spine. So before you want to imbibe, I know you are all come for learning endoscopic surgery. It's always academic inclination is always important, so that you will be progressing much with evidence. When you are the first generation of endoscope, now it has become gold standard, but when we started, we need to discuss more of academics with the conventional surgeons, because the acceptance comes with papers. So even the next generation, we should start writing papers so that this will become more gold standard like a laparoscopic surgery. So this is the multiple papers of spine endoscopy, why it is gold standard. So this again, the next topic is about what, depending on the approach, what kind of endoscopic techniques we are going to do about. So of course, evidence-based medicine comes with initially with the expert opinion, then case reports, then case control studies and cohort studies and RCTs. Once it becomes a systemic review, then the meta-analysis comes in, it becomes gold standard. So any kind of procedure, even for intradural tumors to extradural tumors, it depends upon the case number and always the systemic review. And now the systemic review is skyrocketing. These are various papers. See, this is the skyrocket of papers in endoscopic spine surgery among multiple countries. There is almost zero for degenerative spine in most of the Asian, South Asian countries, where they stopped doing open surgery. When I went to be Asia Mist, some spine surgeon has come down and said that I do open surgery. He said we don't want to discuss it because you are doing the old techniques. It's a new technique. So it has become gold standard. So you know the old techniques, we are happy, but it has become a gold standard now. So this is a AI algorithm of all the 400 papers which are there to support endoscopic discectomy and microdiscectomy, the plus minus in the present run. So the VAS score was definitely good in endoscopic discectomy. The final follow-up ODA is comparatively good. I am talking about true microscopic discectomy. This is a paper, I am not talking about conventional laminectomy with a microscope. I am talking about tubes. With tubes you do a microdiscectomy, that's what we talk about. So the ODA scores at final follow-up was very good. And surprisingly, the duration of surgery is far more faster in endoscopic discectomy than microdiscectomy. The length of hospital stay is, of course, the endoscopic discectomy is faster. So these superiority indices for the functional outcomes were very good. The duration of surgery was good, faster. The length of hospital stay was less. The non-inferiority in the outcomes, in the final outcomes after 6 months or 9 months follow-up is, the VAS score is similar. And the recurrence rates is always similar, because recurrence is more of not a iatrogenic cause. It is mostly depends on the degenerative cause of the patient. The reoperation rate was similar. Return to work period was almost similar in the final follow-up after 9 months. So, this proves that endoscopic disability has the potential to take out the place of microdiscectomy as the gold standard of care in the management of lumbar disc disease. So, this is one more paper. This is one more paper. So, you can see the skyrocket of papers from for endoscopic spine surgery. From 2019, there is around 400 papers coming around every year for about endoscopic spine surgery. So, if somebody says that open surgery is still gold standard, so you can show them that the other surgeons are not fools enough to discuss about it. So, this is the skyrocket of papers from China. There are around 400 papers. South Korea has 256 papers, and USA surprisingly is more of a implant-driven spine surgery. The highest amount of implant-driven is in US and the Europe, but still they have good number of endoscopic techniques to prove that they have good papers. And Germany, you know, they were the pioneers to start, and surprisingly India is lacking in papers. So we'll talk about fusion and all next time. So these are special instruments, how we are able to do monoportal fusions. So I want to discuss evolution of endoscopy techniques, how we started. I started with a simple interlaminar discectomy of a right-sided paracentral disc herniation. You can see the cranial lamina. That is the cranial lamina. There is a traversing root. That is a disc herniation. So we are able to do good amount of discectomies initially. This is how you start with good interlaminar window for I'm talking about interlaminar or PSLD surgeries. Second case is about a central disc. So central calcified discs were initially, calcified disc is always complicated even in conventional open surgery because it is still debatable to open the calcified disc or not open the calcified disc. So I always get a CT, we'll discuss about it later. So you can see the post-operative scan that it is, they say it is literally impossible to do a central disc herniation. You can see the herniation has been clearly improved. This is the same video of the before you have seen. So this is one more portal to do contralateral discectomy so that I can do complete bilateral discectomy with the same needle, same approach. See, if it is a right-sided entry, I don't take in one more left side entry, I just use one more port to do bilateral discectomy which is visualized with the same port. Then obesity. Obesity is one of your favorite things because you start with the bone. This patient is a BMI of 42, obese, short individual. See, you can see the patient is short. So a small laminar defect, you can see the traversing root, partial flavectomy, discectomy has been done, patient is discharged next day post-operative. Then canal stenosis. Then after you doing good number of initially paracentral disc herniations of L4, L5 or L5, S1, you can slowly evolve into doing canal stenosis because as you know, if the flavum ends in some part of cranial lamina, you can finish the end of the flavum, there is no compression. Some people initially thought laminectomy was a gold standard, then started with hemilaminectomies, then quadrilaminotomy, and ultimately it has been concluded if there is no flavum, there is no compression. Unnecessary bone dissection is again problem for the sagittal balance. So I feel you can have this kind of stenosis, you can have a bird's eye view, complete ipsilateral decompression. You can see the ipsilateral root, you can see the central cord, so you can see the caudal lamina. There is not even a single bit of flavum left over. So you can see both the roots are free. There is no disc herniation. So you expect the patient to have a good functional outcome because you can have a bird's eye view what you see in a regular conventional surgery. The canal stenosis has been well achieved. So two levels, initially people are doing hemilaminectomy. So you can just walk over the spine. You can use a jumping technique. So this is the L3, L4 canal stenosis. We have finished the decompression. Just walk it over the lamina without destroying it, keeping it intact, and do the L4, L5. So 2 levels, single incision. So now we are going up to 3 levels. Cervical, it is called a sliding technique. Lumbar is called a jumping technique. Without much muscular damage, we are able to do 2 level decompression with single incision. Then comes the fusion. Even Mayer's grade 3 or a grade 3 spondylolisthesis also, it's the same. Monoportal with the good tools, drills, chisels. You can do bilateral fasciectomy. So, and we can do under visualization end plate preparation. I was showing the previous slide. We'll talk about later about PSL because this is not a, it is a beginners conference. So we could achieve almost full reduction of the spine. Yes, so you can see, as I told, we always just all the fusions. TLIF is most considered best because, according to me, foraminal stenosis is the main component in listhesis. So if you are not decompressing the existing nerve, just decompress the traversing nerve route, it will be a indirect decompression. So you can decompress the traversing nerve route and existing nerve route and knock off the facet and put a good, nice transverse cage. Then the perception of cervical spine surgery has completely changed with endoscopic surgery. All the posterolateral herniations other than the cord manipulation, so is not required. It can be well tackled because you know the dorsal ACDF is a indirect decompression. Though it is a central disc removal, it is just breaking of the oncovertebral joints may decrease the foraminal stenosis, but it is indirect. This is a direct visualization of the foramen, direct visualization of the sensory, and you know dorsal carries the sensory and the ventral carries the motor aspect. That's the reason why in ACDF surgery still patients will have sensory dysthesias, but in posterior surgeries once you decompress the dorsal and ventral aspect of the nerve root, you can patient will have good functional outcomes. Then comes myelopathies. So when I had a stable OPLL, I feel I was able to do 3 level decompression of cervical lamina with a single port because the laminars are just sliding. So you can start from C3 to C6 laminectomy with a single scar. Bilateral decompression. So complications, you know, I feel the complications will come down if you follow the algorithm what Dr. Prasad sir tells. It's about antibiotic or it's about this thing. The only complication I had was 2 or 3 cases of discitis. Discitis is sometimes patient prone, we can't always say. It is not iatrogenic. I had a dural tear which I didn't see it. Most of the dural tears intraoperative, we are also suturing it. We have now good lyophilic agents like Duragen, Tacosil. Then there is a Hemorap, new one from Baxter. Under vision, you can see it forms a good layer over the dura. And most of the dural rents are very small. So you can just take care of it. This case, the pseudomeninges I will present next time. We have done again endoscopy. We have gone through it, removed the, found the new bone, removed the membrane, started seeing the neural structures from the higher end, just removed the fibrous tissue, seen the rootlets, pushed the Duragen and came out. So these are around 1040 cases, initial experience of what all the cases I have done. So it's around L4, L5 is around, you know, it's bread and butter is L4, L5 and L5, S1. Cervical is around 30 to 40 cases, fusions around 50 to 70 cases. So I had only recurrence of around 4 cases, a dural tear of 3 cases and discitis of only 1 case. It was fulminant, patient was diabetic, but post-operative hematoma, we'll discuss about it, why hematoma is a protection or it is a good or bad, we'll discuss it about later. So if the hematoma is not happening in the first 4 hours, if there is no deficit, no cauda symptoms, no neuropraxia, 4 hours after surgery, hematoma is a protection. So don't always see the post-operative MRI and feel hematoma is a risk. Hematoma is a protection for the spine. So we'll discuss it about it once the slides goes around. So thank you. This is the evolution of endoscopy. Now we are going in a more good trend because it is just like a joystick. So newer techniques, newer interventions, newer pathologies are well addressed. Even higher cervical, CVJ junction we are doing. We have published Arnold Chiari decompression. We have done C1 arch laminectomy. Posterior laminectomies we have seen already. So what all things you expect, even anterior ACDF is also very much possible with endoscope. So endoscope is just like a joystick. So but endoscopic anatomy is totally different. So if you are in a delusion that open anatomy and endoscopic anatomy are same, you may fall in a pitfall, so your selection will be in a wrong way. If you go these classes together, you know what is a pain generator, what is central stenosis, what is lateral recess with foraminal stenosis. It is due to disc or due to flavum hypertrophy. It can be addressed transforaminally or it can be addressed only with interlaminar. So what is the orientation of the facets? The facets are straight or facets are not straight. What is the chance of you creating iatrogenic injury to the bone? These all perception changes when you follow the each and every step of lecture here. So you are taking up of case for a procedure you want to do. It can be a transforaminal or interlaminar. A true endoscopic surgery is going to be very clean. The results will be fascinating and your confidence level will be well maintained. So if you don't know the endoscopic anatomy, you don't know the perception of taking, see, for me a stable is this, I still go for decompression because I don't destroy the facets. But that perception, you should know that this is going to progress or not, and you should know the facets are wet or not, and that axial back pain is due to the facets or not. So they again brushing up the pathophysiology, anatomy, and the physiology of the functional biomechanics of spine is well understood. You can achieve the full outcomes with very good morale. So I feel this is the evolution of endoscopic spine surgery at the present moment.